Thank you very much again for logging in tonight and listening to our webinar on multifocal GP lenses. Tonight's webinar is sponsored by Precision Technology and Bausch & Lomb and the Boston Lens Materials Group. My name is Randy Kojima, and I'm one of the consultants at Precision Technology in Vancouver, Canada. And I'm excited tonight to share with you some of our thoughts on fitting multifocal GPs. Now, one of the questions you might ask is, why is it that there's such a small percentage of fits out there that are done in multifocal contact lenses? In the surveys done, probably the most well-known is the Contact Lens Spectrum Survey, and they found that 11% of the soft lenses were multifocal lenses, and of all the GPs fit, 13% of all the GPs dispensed were multifocal lenses. Yet, of the vision correction population, 58% of patients are 45 years or older. So we're clearly not fitting an equal number of multifocal contact lenses based on the size of the population, which is interesting. Now, as an answer of why we don't fit more multifocals, you might want to look up this study by Ravi Bhattacharya, and he did this really interesting test of multiple lenses, basically all the major lenses on the market. And what he did was use a retinal camera, imaged through a model eye, through the contact lens, the soft multifocal, and then imaged the eye chart. The idea was to get some perspective on the kind of acuity the patient would see at 3 meters, 1 meter, or a half meter, and to give you some idea of how the chart would appear to a patient based on near, intermediate, or distance through each of the contact lenses tested. And as you can see from the images below, the E's are pretty tough to make out on these acuity charts. So it's a bit of a challenge getting quality vision through our soft multifocal lenses, which we know sometimes they perform better than in other patients. And why is that? And we'll hopefully address some of those answers tonight. Now, we know that GP lenses have always offered the best optics, and there's numerous studies to back this up, but a more recent study by Hong and his group at the University of Indiana looked at aberrometry through spectacle lenses, soft lenses, and GPs, and clearly the GP lens offers patients the lowest aberrations, and one would expect the best quality optics. So that is a major factor in why we may get better results from our GP lenses, or maybe conversely why we haven't had such great results through our soft multifocal lenses. And if you want to test this, you don't need a Hartmann-Shack barometer to do that. You can pull out your lensometer and just throw on a soft lens or throw on a GP lens and look at the Myers through your lensometer, and you will see a huge difference whether you're looking at a single vision lens or a multifocal lens. Or if you have a corneal topographer, image over top of the contact lens on eye and look at the shape of the anterior surface. Which one corrects the imperfect shape of the cornea better than the other? And you will find that in both tests the GP really outperforms the soft. And maybe that's why the percentage of GP multifocals fit are slightly higher. Now, we know that we ask a lot of our multifocal lenses if we have an aspheric design lens with most plus in the center, then you would see a power spectrum similar to this, plus in the center, minus toward the outside. If it's a distance center lens, we have most minus in the center, most plus toward the outside, and then we have a number of lenses that offer multiple zones of distance, near, distance, near, distance. So we've got a number of different designs, and which one is the best? I'm not sure that we've seen that one has proven itself to be better than the next. But what may be working against us, why as a whole we don't see much better results with our multifocals, is that anatomy may be working against us to a degree, and part of that is our temporally displaced fovea and the fact that patients are looking through the nasal aspect of our contact lenses. If any contact lens is centered to the cornea, is geometrically centered on eye, here the patient is actually looking through the nasal side of the optics. So even in a perfectly centered contact lens, our patient is never looking through the center of the lens. And in a multifocal lens with multiple powers distributed, we want to make sure that we're well distributing those powers. So that's one important consideration, is where is the patient looking through the optics of the lens. Now, you can see that when you do corneal topography on a patient. For instance, the center of the grid here is the patient's visual axis, and you can see how the topographer is imaging a lot of the nasal cornea here, but missing a lot of the temporal side here, and that's because the patient is fixating down the axis of the instrument using their temporally displaced fovea, and that results in a photo that's skewed off on the nasal side. Similarly, if you look at the placido reflection, just the rings, the center is where the patient is fixated. But this little white cross is the center of this white circle, what I think is the geometric axis of this cornea. And you can see the kind of displacement you have. It's about 3/4 of a millimeter of displacement from the geometric center of the cornea to the visual axis. So if our contact lens centers perfectly to the geometric axis, the visual axis is going to be about 2/3 of a millimeter out of center. So that could adversely affect the kind of quality of vision that this patient would receive. Now, we were curious about this whole angle lambda and temporally displaced fovea and how lenses appear to be slightly temporal of center optically. So we took all the major brands and put them on our healthy, normal students in 3rd year, and have a look at some of the results. What you see here is a corneal topography taken with the naked eye, so a regular corneal topography. Then this is the topography taken over top of the Acuvue Oasys multifocal. On this side, what you're seeing is the difference between naked cornea, no lens, and the cornea with the lens over top. And in the center, this is the visual axis. And this pink would be a 4 millimeter pupil that we drew in. The yellow circle is where we believed the concentric rings were, or the optic zone in the soft multifocal. And what do you notice? If this is the visual axis, and this would be a pupil centered perfectly to the visual axis, then our contact lens, drawn in with this yellow circle in the zones of the distance here, the blue, you can see that it's clearly left of center. So our contact lens is temporal on this right eye. You can tell it's a right eye because the placido reflection is hitting the nasal side, and we're not imaging a lot of the temporal side. So our Acuvue lens appears to be temporal of center. Now, what if we put on the Purevision on this patient? Same thing. Here's the visual axis. The pink would be a 4 millimeter pupil that we've drawn in. And then if we draw this yellow circle around one of the inner zones of the lens, you can see again that the contact lens is temporal of the visual axis, and also slightly superior as well. And I should add that each one of these lenses were optimized for fit, yet they still wanted to ride temporal of the visual axis, which does make sense, of course, because we have a temporally displaced fovea, so the patient should always be looking through the nasal aspect of the contact lens. Now, here's the air optics. In the center of our grid, we have the visual axis. Pink would be the pupil, yellow would be the zones of the lens, and again temporal. And one very powerful thing if you have a corneal topographer is you can use this method to understand what powers are actually distributed within the pupil. Here we can see we've got the most plus, the warmest color in the center, and we're getting a little bit of the most minus on the nasal side, but we're not getting all of this higher amount of distance out here. So you'd certainly expect this lens would favor near vision, where we've got all of the plus in the center, but not quite all of the minus in the periphery. Let's look at the Biofinity Distance lens. Here's the visual axis. Pink is our pupil, yellow are the zones of the lens. And notice how temporally displaced our multifocal contact lens is. Again, we're fighting angle lambda. The lens may be perfectly on center, but it's our displacement of fovea slightly temporally that's resulting in the patient fixating through the nasal aspect of our lenses. Now here's the Biofinity Near lens, and you can see most plus now in the center, most minus toward the outside. But again, looking at the pink, where we would draw in the pupil based on the center of the visual axis. The yellow being the zones of the lens, we're appearing temporal of center. So all of our contact lenses, in each one of the cases, we did 10 different students and 5 different major brands of lenses, and every one of them wanted to be slightly temporal or significantly temporal of the visual axis. So that led us to do another study, and that was to custom build soft lenses to see if it were possible to perfectly center them on eye, to make sure that this slight temporal decentration we're seeing with the Optix isn't a problem with lens decentration. So we made some custom lenses up based on the diameter of the visible iris diameter, and as well as the measured sagittal depth of the eye. And we ordered custom soft lenses from Alden Optical. And what we found in a small number of cases is that the lenses on eye looked like they were very well centered to the visible iris. And this kind of centration was the exception rather than the rule. Here's another case. Look at the ever so slight decentration temporal of the lens. These are all right eyes. Notice how you can see just a little more sclera on this side than you can on this side. Let's go to our next case. Now we've got a little more decentration. And remember, these lenses were all optimized for best fit. These were comfortable lenses. They moved well. They centered relatively well, but they had slight temporal decentration. And going steeper or going larger did not move the lenses onto geometric center. This is where they wanted to position, ever so slightly temporal. Here's our next case. Again, we have another lens that's vertically well centered, but slightly temporal. Next case, same thing. Slightly temporally decentered lenses. So we were wondering, why is it possible that all of our soft lenses, or pardon me, not all, but the majority of our soft lenses fit, whether they were multifocals or single vision lenses, were ever so slightly temporal. And we found some interesting stuff led by Pat Caroline at Pacific University, and that was at 15 millimeters diameter across the sclera. When you measure the height of the nasal and temporal aspect of the eye, what you're finding is that on the nasal side, the eye is higher than it is on the temporal side. So as a contact lens approaches the cornea or approaches the eye, it's going to hit on the nasal side faster than it will on the temporal side. There's more depth temporally. So what we found was that out of the 18 right eyes that we imaged, the nasal side was higher in 15 of the 18 eyes. Then when you go out to the 20 millimeter cord, 18 of 18 eyes were higher on the nasal side. So the elevation of the surface based on the plane of the eye was much higher. On the temporal side, the distance to the surface was much greater. So what we believe is happening is as the contact lens comes on center, it hits the nasal side and it has farther to fall on the temporal side, which results in the lenses riding slightly temporally. Although it would appear that it's a significant difference, on eye it doesn't create a big loss in comfort. The movement of the lenses is not a problem. The centration is temporal, but it's not temporal enough that it causes a big problem with single vision optics. Now what about the left eye? And this was interesting. On the left eyes, the temporal side of the eye was actually higher in 11 of 18 eyes than the nasal side was. So it was reverse of the right eyes. However, the average difference between nasal and temporal was a tiny, tiny little amount. So this is really unusual. It appears that the nasal and temporal sides on the left eyes are much more symmetrical than they are on right eyes. So as my colleague Pat Caroline joked from Pacific University, we should fit all of our soft lenses on left eyes only, because on right eyes they're all going to decenter temporally. But interestingly, again, at the 20 millimeter chord, now we're seeing again that the nasal side in 18 of 18 eyes was higher than it was on the temporal side. So the larger the lens we use, be it a scleral lens or a soft lens, the more likely it might be to decenter temporally. Now, we also have some other anatomical features working against us, and if you get a chance to read Bernd Bruckner's thesis or his paper on soft multifocal lenses and some of the anatomical contributions that affect the quality of vision, one of the interesting things he found was that the pupils in both right and left eyes were decentered slightly nasal of the geometric axis or of the visual axis. So we have not only the temporally displaced fovea resulting in our patients looking through the nasal aspect of our contact lenses, but also the pupil is displaced nasal of where our contact lenses may be centering. So both these factors work against us. Then consider that with the senile miosis in the aging patients, we have a smaller and smaller pupil to work with, and therefore to squeeze in all the multifocal powers that we need. So we need to be cognizant that we're dealing with a much smaller surface area with our presbyopes to make that power available to them. So some of the challenges that we face, number one with soft multifocals, are the quality of the optics, and we've known that for a long time. We need to compress the powers into this very small surface area, and that works against us both in soft and GP lenses. Then we've got that temporal decentration of soft lenses that's normal, and it's due to the nasal aspect of the eye being higher than the temporal aspect of the eye. And when you get back to practice tomorrow, it'll be interesting for you to look at some of your both single vision and multifocal soft lenses and see if you pick up on that ever so slight temporal decentration. Vertically, they're generally well centered, but slightly temporal. So that means that the patient is looking through the nasal aspect of the optics. And with our temporally displaced fovea, the patient is naturally fixated generally through the nasal aspect of the lens. And then, of course, with our senile miosis, we've got to distribute the powers over a smaller surface area. Now, do GPs offer more hope? Are they a better option? And certainly optically, we know GPs should improve upon the quality of vision that a patient would get through a multifocal lens. But we still face the same problem as soft multifocals. We have to compress all the powers into a small surface area to try to provide simultaneous vision. We don't have the problems with temporally displaced lenses because we're dealing with cornea alone. And if the cornea is symmetrical, then chances are our GP will center well, at least to the geometric axis of the eye. We'll still have the nasal displacement of the pupil and the nasal displacement of the visual axis as a problem. And then senile miosis is still an issue, although it may be less of an issue with GP lenses because we can custom construct each lens for the diameter of pupil that you're facing. Now, how do we actually fit these lenses? Let's discuss this in this next section. And we have primarily two designs that dominate the market today. One is the aspheric multifocal that's like a progressive multifocal, either most minus in the center or most plus in the center, and progressive power toward the outside. The other lens that dominates the market would be the translating bifocal or trifocal lens. And I probably shouldn't use dominating because really the aspheric multifocal represents the lion's share of the multifocals fit in practice. Translating bifocals and trifocals are awesome. They're awesome because the patient has this large area of distance and this large area of near with which to get really good quality vision from. The challenge of the translating lenses is they need some prism ballasting to keep them on axis so they're not rotating around. So we have the seg line running across the horizontal meridian. We have to get the seg height just right. So the distance from the lower lid to the inferior pupil margin needs to be pretty close because as the patient looks down to read, the lens needs to move up enough that the patient gets into this plus down below. So there's a little more work involved in the translating bifocals and trifocals, and that may be why they represent a much smaller area of the multifocals fit on our presbyopes, at least in the GPs. Now within the aspheric multifocals, if we say that these lenses are carrying the lion's share of the fits that we do across North America, then there are two approaches that you might face, two different constructions of lenses. And the first would be your central or your superior central lid attach fit, and they're typically in conventional diameter of lenses like 9.2, 9.5, maybe 9.8 diameters. The other approach would be the centered simultaneous fit, and they tend to be larger diameter lenses like 10.2, 10.5, 11.0 diameter. And we'll go through each so you understand both approaches. And they're both good, they both work. Now, before we fit any RGP lenses, it's really important that we understand the shape of the eye, because if you've got a displaced cornea, you're never going to have the GP lens position where you want it to. And it's less important to look at your corneal apex on your topography. It's more important to look at the peripheral corneal shape. That governs where the lens positions. Now, certainly gravity and lid force are very strong factors, but if we rule out lid force and gravity, the next or the only controllable thing that we have is to understand how to align the lens to the peripheral cornea. And here we see this yellow-green area of flattening looks very well centered to the geometric axis of the eye. So I'm thinking if I fit this patient with the GP multifocal or any lens that would center to the cornea, then the chances are we'd have the optics ideally situated on this eye. Now, how about on this patient? Again, ignore the corneal apex because it's not as important. We vault the central cornea with our RGP, so the center is not as important as what exists out here in the periphery. And if we draw this dotted circle in, look at where your RGP might land and find its equilibrium. This green-yellow area at about 8 to 9 millimeters out is where the lens is going to plunk itself down and touch the surface of the eye. And what we're seeing is a corneal apex slightly high and slightly temporal. So if we're trying to perfectly center our multifocal GP on this eye, it's going to be a bit of a challenge. Now, when you look at the 5 of these different patients, 5 of these different topographies, which one of these patients would you presume would be an ideal multifocal RGP wearer? and which ones would not. And we might look at the one in the center and say, look at the yellow-green contours. This is a left eye. You can tell from the blue on the nasal side here. It looks like the contours are all stretched temporally. They're all stretched in this direction. So any contact lens I drop, any RGP I drop on this patient is probably going to want to center the optics slightly temporal of the visual axis, right in the center. On this patient, we've got a displaced apex, but more importantly, look at the green-yellow out here and the fact that it's right off the topography down here. So on this eye, we'd expect the lens to want to ride low. This might be problematic for trying to center the optics where we need them. Again here, same thing. We've got a patient that has a contour, the yellow-green, that appears to be pushed more temporal. And in this case, we see the green-yellow appearing more superior. So any lens we drop on this patient is likely going to want to ride high. And let's not fight nature with the lenses, the patients that we choose for multifocal GPs. Here's a patient that's probably an excellent candidate, and excellent because we look at the green-yellow and say it's fairly well centered to the visual axis in the center. Maybe ever so slightly low, but generally quite symmetrical a corneal topography. Now, another thing to consider is not just the degree of astigmatism, not just how steep or how flat the eye, but whether it's apical or limbus to limbus astigmatism. These two eyes are very similar in corneal sill, 1.6 diopters here and 1.5 here. However, look at the peripheral corneal astigmatism. This patient doesn't have a figure 8 that extends all the way past the pupillary zone. Really, this patient has very centralized astigmatism, or what we call apical astigmatism. The image on the right is similar central corneal sill, but you see the peripheral corneal sill is much different. This patient has what's called limbus to limbus astigmatism. Now, so what? They're both the same central corneal sill. Why does it matter that we need to know the difference? And the reason is the apical astigmatism generally fits well in a symmetrical spherical GP lens, a non-toric GP. The patient on the right with this limbus to limbus astigmatism, even with such a moderate amount of corneal sill, will probably do better in a bitoric or backtoric lens because this meridian is simply much, much deeper than this meridian. And if you've ever fit a patient with a moderate amount of sill and wondered why the lens wanted to decenter superior or tilt across that vertical meridian so significantly, and no matter how much steeper you went, you couldn't reduce the amount of tilting that existed, chances are it was a limbus to limbus corneal astigmat. One of the lenses that we use at Precision that is probably the most prescribed lens in North America are the Essential series of GP aspheric multifocals. And the way they're designed, it's most minus in the center, most plus toward the outside. So if the patient has a lens reasonably well centered, they should be looking through the most minus in the center. Then for intermediate vision, this is a progressive, so you have more and more plus as you move away from center, picking up the maximum plus toward the periphery. So as the pupil would dilate, we'd pick up the greatest amount of plus available in the lens designs. Now, when you look at the cross-section of power that's produced with these lenses, it's really interesting. In the center, you have the most minus, or your distance vision, and then at a 0.5 millimeter out, the ad starts to kick in, so 0.5 millimeter from center, we have only 0.12 diopters of ad. As we go to 1 millimeter from center, now the ad is starting to kick in. You see in the highest series, series 3, we're starting to get more ad. Then we go 1.5 millimeters out. In the lowest series, we have only 0.75 diopters of ad created, but at the same distance, 1.5 millimeters from center, in the series 3 lens, we have almost double the amount of ad created. As we go even farther to the 2 millimeter from center measurement, the lowest series ad has 1.62 diopters. The series 3, again, almost double. And then at the 2.5 millimeter, we see much less ad created at 2.5 millimeters in the series 1, much more in the series 3 ad. So you'd use the series 1 lens for low ad patients and also in the dominant eye. Generally, you fit the series binocularly. If the patient's a 2 ad, you might use a series 2 in both eyes, but you might find if you're having trouble with distance vision that putting a series 1, the lower ad, with the bigger zone of distance may be more effective for quality of distance vision. And that's obvious in the cross-section here. This would be your series 1 cross-section of power. And you see this area of blue in the center, which would represent your distance zone of your series 1 ad. Then when you go to a series 2, you're getting a smaller distance area, and the plus is ramping up more significantly. As you go to a series 3, the distance area gets smaller, and then the ad ramping up much more aggressively toward the periphery. So when you want to improve distance vision and changing the power of the lens just doesn't do it, then you might find going lower in series, effectively lower in ad, will improve your distance vision. Notice that it's an aspheric, so you're still getting intermediate in here. You're still getting plus power even if you reduce the series ad. But consider also if you go to the higher series of ad, then you're getting a much smaller distance area. So try not to push too high an ad where you don't need it, especially in the dominant eye. Now, the way the lens should center, in primary gaze, we want the lens to be reasonably well-centered or slightly superior central. Basically, Blanchard says a good RGP fit. So that would facilitate the patient looking through the majority of the most minus in the center. Now, when the patient looks down to read, the lens either stays lid attached or the lens hits the lower lid and translates up ever so slightly. And that way we get into more of the plus around the outside. So in primary gaze, the lens should be reasonably well centered. When the patient looks down to read, lens should translate up slightly. So that's an important tip. Make sure that when you're evaluating your lenses, don't only look at the power the patient's taking over the lens, but also look at the position of the lens. Now for distance vision, what we want to see is a lens that rides slightly superior central or central. And that is what Blanchard calls the most optimal position for their lenses. That gives you a distribution of both distance and near powers and possibly simultaneous vision. So we're looking first for the centration of the lens. That's the very first thing you should look at with your essential multifocals. Now for near vision, when the patient looks down to read, observe from the side where the lens is positioned. So go to the side of the patient with a pen light, ask the patient to look down to read, and see if the lens stays lid attached or does it hit the lower lid and take a slightly superior position. And that way you can be assured the patient should be getting into more of the plus toward the periphery. Now if the centration of the lens isn't optimal, we just apply our normal GP rules. If the fluorescein pattern isn't clearly steep or flat, we're going to assume if the lens rides high, it's probably too flat. So we'll go steeper, maybe a half diopter or more. If the lens is laterally decentering, then look at whether you have against the rule astigmatism. If you do, this might be as good as it gets. We can always try a little bit steeper, but on against the rule patients, their decentration tends to want to be nasal and temporal. But if you're dealing with a spherical patient or a with the rule patient, if the lens is laterally decentering, then we'll probably go steeper or go larger or both. Then lastly, if again the pattern isn't completely clear whether it's steep or flat, but the lens is riding low, then we'll flatten the base curve a half diopter to try to loosen the fit up and allow the lid to pull the lens up. Now, if you have poor distance VA, obviously we're going to check the power, we're going to over-refract, see what kind of minus the patient takes over top of the lens. If that minus does not affect the near power, then we'll incorporate into the lens and we should have a successful outcome. However, if the power does affect the near vision, if you push minus into the lens and that reduces your near VA, then look at the centration of the lens. Is it really not a power issue? Is it more that the patient is so far out of the center optics of the lens where the most minus is that we're well into the plus, and it's simply if we could center the lens better, we'd have the patient looking through the most minus. So it's not just power that we need to be concerned with. With multifocal GPs, centration is everything. Now what about the near vision? If the near vision is poor, again the first thing we'll check is to see if we can add more plus. If adding a half diopter of plus gives us the near VA we need, and it doesn't affect the distance vision, then we can incorporate that into a new lens. If adding more plus to the power of the lens does affect the distance, then check the translation of the lens. Is it staying well centered when the patient looks down to read and the patient is looking through the most minus and not more of the plus toward the outside? Or is the lens decentering so much that you're into the optic zone junction and that's causing aberrations, so we're losing VA? If everything looks like it's supposed to, and the lens is well centered and there doesn't seem to be power you can modify, then change the series, go to a different series of add. So for instance, if our distance vision were poor and we were in a series 2 add and the lens was well centered, we would reorder as a series 1 add. We'd make that distance zone larger in the dominant eye only and leave the non-dominant eye as is if possible. If the patient has poor near VA, then we might want to go to a higher series add and push more plus closer to the center, make it easier for the patient to get into. So you've got 3 designs with the essential, all of these being a center to superior central RGP multifocal fit, meaning we want the lens to be reasonably well centered or maybe superior central lid attached fits, but then when the patient looks down to read, the lens should hit the lower lid and move up slightly. So you have the essential, which fits slightly flatter than the essential extra. It's a little bit of a steeper fitting lens. So if we have a notoriously high riding single vision patient that's upgrading to multifocal lenses, and then we might want to consider using the essential extra because it fits a little bit tighter. The Reclaim is the newest lens in the family, and what it uses is a front surface add, which it's claimed that patients pick up the add a little easier in this lens because the add is on the front surface and measured in air, not with tear layer on the back surface that may neutralize some of the add. So having the add on the front effectively may give you more magnification. And the Reclaim allows you to modify the size of each zone based on the pupil size, which is very helpful. A benefit of the Essential series is that you can empirically order. You can order by Kaizen-RX. You don't necessarily need a trial set. You have no risk if you order the lenses, and 2 exchanges to try to get things right. If it doesn't work out, you can return the lenses for full credit, which is great. Now I said that there were 2 designs, 2 philosophies that we might use to fit aspheric multifocals, and the Essential series would be your superior central kind of pseudo-translating lens design. An aspheric lens, but an aspheric lens that works well when it moves up slightly for near. The other alternative is to fit a centered simultaneous vision lens that doesn't translate, that hopefully stays well centered on eye. Now when you look at the optics of a multifocal contact lens and the way the powers are distributed, you see this beautiful concentric steepening as we go to warmer and warmer colors or more and more add. So most minus in the center, most plus toward the outside. And it's this very symmetrical shape that should reduce aberrations significantly. When we measure the aberrations of a multifocal GP, certainly they go up higher, but they don't go up as high as when they're decentered. So if you have a well-centered GP multifocal, then you have the lowest aberrations that are measurable, at least over a multifocal lens. Now what happens when those lenses decenter? When we have a aspheric multifocal lens that rides superior, what then happens with the aberrations? And the aberrations go up quite significantly when we have our multifocal lenses riding very high. And that results in higher radial astigmatism, vertical coma, and spherical aberration. So to reduce the aberrations and try to improve the overall quality of acuity as much as we can, a good idea is to try to center the lenses as much as possible. So to do that, we use as large a diameter of lens as possible for the simultaneous GP multifocals. The less movement you have, the more the comfort improves. So that's an added benefit of using the large diameter lenses. So the idea is use as much of the sagittal depth of the cornea as possible. Go as large a diameter as you can to create as deep a contact lens as possible, and that will result in a lens that should be fairly well centered. So big lenses with the simultaneous vision option. The second thing that we want to do is create a design with these larger lenses that lands very softly on the peripheral cornea. When you use a spherical optic zone on a high eccentricity eye, the normal eccentricity of the eye is about 0.65 roughly, meaning the rate of corneal flattening from the center of the eye to the periphery is approximately 0.65. A zero eccentricity would be a sphere. So this is a spherical lens with zero eccentricity placed on a high eccentricity cornea. And what you see is this very acute point of bearing on the peripheral cornea. When you use a high eccentricity back surface, you create a much wider surface area of landing. So with the larger lenses, we use high aspheric back surfaces to try to soften up how the lens lands on the peripheral cornea, so you don't have these very acute points of bearing effectively. Now, larger means that we're not using 9.2, 9.5, 9.8 diameters. We're using 10.5 as your normal diameter of lens. For the larger eye, you go up to 11. For the smaller eye, you might go down to 10.2 or 10.0. But you want to try to be as large as you can so you create a centered fit and good quality simultaneous vision. Now, we were curious at Pacific University what optics patients were actually getting, or what ads were they actually getting from their lenses. So we ordered a number of lenses from various manufacturers in a 2 1/4 ad, and we measured where the ad actually kicked in. So on this particular lens, what you see is in the center, at the center of the contact lens is 0.0 millimeters away from center, the ad was 0. That's where your most minus was. At 1 millimeter diameter, or if the patient had a 1 millimeter pupil, the ad would still be 0. There was no ad effect at 1 millimeter pupil. At a 2 millimeter pupil, we had a 0.1 diopter ad. At a 3 millimeter pupil, a 0.6 diopter ad. Now remember, with senile miosis, a 60-year-old patient should have approximately a 3 millimeter pupil. So in this case, the lens wouldn't be providing much more than a half diopter of ad at the 3 millimeter pupil. At 4 millimeters, we were getting 1 1/4 ad. At 5 millimeters, we were getting our 2 1/4 ad. So it was a 2 1/4 lens, but it wasn't kicking in till you got out to 5 millimeters. Now let's place that lens that we just ordered on a number of different patients. If we place our lens with a 2 1/4 ad at a 5 millimeter pupil on a patient with a 3 millimeter pupil, then that patient's only getting an ad of 0.6. If we place that exact same lens on a patient with a 4 millimeter pupil, we're only getting 1 1/4 diopters or 1.3 diopters of ad power. At the 5 millimeter pupil, we would be giving the patient a 2 1/4 ad. So you can see that it's important to understand before we build a contact lens, a multifocal for a patient, we need to know the pupil size. This is really, really important. So what did we learn about these simultaneous vision lenses? Number one is centration. It's simply everything. We must have centration to achieve good quality vision and reduce the aberrations as much as possible. Reduce the aberrations, improve the overall quality of acuity. Then we need to know the pupil size. It doesn't help to build a lens with a 2 1/2 diopter ad that kicks in at 5 millimeters when the pupil size is only 3 millimeters. So it's important that we come up with some way to measure pupil size. We use at Pacific University the corneal topographer. It does a very decent job of giving us perspective on the pupil size in normal illumination. So for those of you with corneal topography, have the room lighting at normal levels, so the eye that isn't being imaged, its pupil size will affect the eye that is being imaged behind the instrument. Then, when you call up the lab, you want them to build the lens with the appropriate distribution of power based on the measured pupil in normal illumination. Then consider that when we have those decentered optics, the more superior, or in any direction more decentered the lens becomes, the higher the aberrations will be. So centration is simply everything. Work to achieve as well-centered a lens as you possibly can. Now the nice thing about these kind of optics where they're added to the front of the lens is that they can go on virtually any type of lens. So obviously for single vision patients that are coming from sphere lenses, we could put them into the multifocal. If they're a toric patient, then you simply put the multifocal on the front. If it's a keratoconic patient, the same thing. If the lens is reasonably well centered, then you can put the multifocal on the front. And this would be applicable to scleral lenses as well. So the PTS multifocal is an anterior surface multifocal, which helps because we can put it over top of any lens a patient might be wearing presently. Now, how do you fit this lens? Ks and Rx or topography and Rx are all we need, but you must have the pupil size. This is really important. Even some ballpark idea of 3, 4, 5, or 6 millimeter pupil would be helpful, because then your first lens should hopefully be in the ballpark of the kind of distribution of ad you need. When in doubt, order a smaller pupil than what you think you might be measuring. You'd rather have more ad kicking in inside the pupil than less ad kicking in. At least that way you can assure that the patient should be getting the near vision. If the distance is poor, then we can always go to a lower ad, but we may not know what near magnification is available unless we push it in there. So pupil size is really, really important with these lenses. And when you receive the lenses, make sure that they're well centered. That's the first thing that you have to look for. Do I have a centered RGP lens? And then again, the same rules apply if the fluorescein pattern isn't discernible one way or the other, be it steep or flat. Then if it's riding high, then we'll go steeper a half diopter or more. If it's riding low, we'll go flatter a half diopter or more. If the lens is laterally decentering and it's not an against the rule cornea, then we'll just go larger or steeper to try to bring it back on center. But centration again is everything. And then for near vision, consider what kind of pupil size that you're dealing with. If the patient isn't picking up the plus, but the distance vision seems to be okay and the lens is well centered, then we may need to push the ad closer in a smaller pupil diameter. So consider that when you're having troubles with near vision. If the lens looks like it's well centered in both primary and near gaze, then we may not have pushed the plus close enough into the pupil, or we may not have a high enough magnitude of ad within the pupil size. And then again, centration. Centration is key with these lenses. Over-refract the lenses to see if there's any power that we need over top. If a little bit of plus, like a half diopter, gives you the near that you need and it doesn't affect the distance, then we can custom order another lens with a little more plus. If you push the plus for better near and it affects the distance, then we may need to change how quickly this ad enters the pupil. Maybe we haven't introduced enough plus power into the measured pupil to give this patient the kind of magnification that they require. So it's a simple call to the lab, and the consultants will change the asphericity or change the ad of the lens. Now again, just like the essentials, you have a comprehensive warranty. You can empirically order this lens. There's no risk. You can return it for full credit. You get 2 exchanges to try to get things optimized, and it's 100% credit if it's unsuccessful. So you've got 2 approaches available to you through Precision Technology: a center to superior central lid attach fit, a lens that's designed to translate up slightly when the patient looks down to read, and a simultaneous vision lens that's designed to always be on center and provide simultaneous vision similar to the way a soft lens would. Both of them work. Sometimes the simultaneous vision lens works better than the superior central fit. Sometimes the superior central fit works better than the simultaneous large diameter lens. So it really depends on the patient, and I find it fascinating that we can do everything right and sometimes it just doesn't work. And is that because we have a visual axis that's significantly nasal of where our contact lens is? Is it because our pupil's decentered too much, or the patient isn't looking through the right optics in the lens? Is it the patient's ability to interpret blur? In some patients it's better than in others. We just don't know until we put on a lens. So the only way for you to be able to predict whether things are going to work out well is to put a lens on eye, either a trial lens or empirically custom order the lens you need, and that way you'll be able to tell. But you can look at the baseline topography and see where the visual axis is in relationship with the decentration of the eye. That might give you some idea whether your optics are going to be centered over the pupil or the visual axis. Now again, both these lenses are no risk to try. So if you're unsuccessful with your patient trying either design, then you can return them for full credit. Now, if you're interested in seeing the webinar again, or if you have a colleague that may want to bone up a little bit on their multifocal GP lenses, you can go to YouTube and look up Precision Technology Services. You will see the past webinars that were done on conventional corneal GP lenses, single vision lenses, on myopia control. In about a week, you'll have the recently added presbyopic lecture that we just went through, but there are also other videos on there as well. So go into YouTube, look up Precision Technology, and you'll be able to find additional videos. The next webinar will be on fitting the diseased post-surgical and asymmetrical eye with corneal GP lenses. So before we move into sclerals, let's look at which patients still are good candidates for corneal GPs and how we optimize fit on some very difficult eyes. And that'll be on February 4th, same time Pacific, 6 to 7 p.m. Pacific time or Vancouver time. And if you're registered for this webinar, you'll automatically receive the invitation for the next webinar. If you're interested in bringing orthokeratology or myopia control to your practice, we're offering 2 seminars in both Vancouver and Toronto on March 7th and 8th in Vancouver, March 14th and 15th in Toronto. It'll be a 2-day course, Friday evening and then Saturday morning, and then the afternoon we're going to focus on scleral lenses. So Pat, Caroline, and I from Pacific University will be doing 9 hours of COPE CE, and basically fitting patients, talking about the myopia control studies, talking about the procedures involved for both ortho-K lenses, myopia control glasses, myopia control soft lenses. We'll talk about how to problem solve your lenses, and then in the afternoon session we're going to focus on scleral lenses because it is such a hot topic in contact lenses these days. So thank you very much for your time. I really appreciate you giving up a part of an evening to be with me tonight to learn about multifocal GP lenses. In the next section we're going to answer any questions that you might have, so you can stay tuned, but thank you very much. So I'll look up some of the questions that may have been posted, and I encourage you to enter in anything that that you would like to address that maybe I didn't during the course of the seminar. So I'm just going through the questions now. Is there any difference in the Asian versus Caucasian eyes with multifocal lenses on these patients? And we can say in terms of the angle lambda, or how temporally displaced the fovea is, we don't know that there's any differences between Asians or Caucasians. And as far as the elevation differences between nasal and temporal sides at 15 or 20 millimeters in our study at Pacific, it may have been too small, but we definitely had both Asian and Caucasian patients, and we didn't see any difference there. They were primarily highest on the nasal side, lowest on the temporal side. So we shouldn't expect to see outcomes different for these patients. However, it's a good question, because likely with the smaller fissure size and tight lids, the Asian patient may pull the lens up higher. So in a simultaneous vision lens like the Precision Multifocal, this may not be the best patient for that lens if the lid is going to want to pull the lens up. That might be a better candidate for a slightly superior central pseudo-translating lens. Another question, could you change the diameter instead of flattening or steepening the lens? And you certainly can. For every 3/10 you go larger or smaller. You should change the base curve about 1/4 diopter. So if you simply wanted to create a tighter fit, then by going larger 0.3 millimeters effectively is like fitting 1/4 steeper in base curve, although I think the actual on-eye fit is much tighter. It's much more than just 1/4 diopter. As you know, if we want to make a significant change to an RGP, we would normally change the base curve 1/2 diopter, but in diameter, 3/10 is usually a significant change. But to compensate for sagittal changes, 1/4 diopter is what you might want to change the lens by. When considering older patients with smaller pupils, are there GP multifocals with center add powers, or are they all center distance lenses? For the most part, I'm not aware of too many lenses that have most plus in the center, but it's certainly doable. I know the different manufacturers may be able to create those. We do not. All of our lenses that we do are all most minus in the center, most plus toward the outside. And that it's probably a good question, because it similar to what we've done with soft lenses by having most plus in the center for the dominant, the non-dominant eye, most minus in the center for the non-dominant eyes, has worked as a reasonably decent alternative to having both lenses most minus or both lenses most plus. A question, how accurate is the Medmont for measuring the pupil? The instrument is very accurate to within a tenth of a millimeter of pupil, so we feel pretty confident that most topographers will do a good job of measuring pupil size. The important thing is to have room lighting normal as a patient would read, so that the pupil size of the eye that's not being read, that's not being captured on, will hopefully affect the size of the eye that's being read. That way you'll have a much more accurate determination of the reading pupil. And then next question, when dealing with smaller pupils, do you suggest pushing the ads like Series 3, or do you choose a translating design to get around a small pupil? So I think a very good question. When you've got that very small pupil and you're dealing with a translating lens, with the natural superior displacement, you might automatically be into more plus there anyway. If you're using a simultaneous vision lens, then definitely going to the highest add or pushing the plus as close to the center makes a lot of sense. In the non-dominant eye, I wouldn't want to over plus or push too much asphericity into the dominant eye, fearing that with that smaller distance zone we may lose some of the distance VA. Does the Essential series flatten the cornea compared with the Reclaim? And the Reclaim is a symmetrical back surface, a spherical back surface, so it's designed to function like a single vision lens would with a normal spherical base curve radii. So the Reclaim should not be producing changes in the corneal shape. The back surface aspherics like the Essential or the Essential Extra could definitely change central corneal shape, although we don't find it has made that many changes to central cornea like we did with some of the earlier aspheric multifocals, but it definitely does come up from time to time. So I think you'll find better outcomes with the Reclaim that way, because it's effectively like dealing with the normal geometry of single vision GP without that cap, without that steep center that could create a hydraulic force that gave us some of the spectacle blur that we saw in the early designs. A question, how often have you found the composite Medmont maps for predicting corneal GP fit? And the answer is I don't know yet how accurate the composite is with constructing GP lenses. The engineers at Medmont will tell us that by averaging out a number of maps, that should do a better job for designing the entire lens. But truth is, at least my experience has only been with using singular maps, and I've only started to use the composite. So I wish I had a better answer for you at this point. Another question, can the E-values be trusted for empirically ordering, or do you still sorry, I lost my question. Can be trusted for the empirical ordering, or do you still need to trial fit since E-value can be skewed outside the 7mm zone? Yeah, it's, as you know, eccentricity varies from one patient to the next. The amount of central corneal astigmatism, peripheral corneal astigmatism, the discrepancy between the flat and the steep meridian and how the eye flattens out, corneal displacement, they're all significant factors. A trial set is always helpful to have, because you can tell right away, can I, number one, center these lenses? Number two, will the patient be able to get decent vision? One thing that I think was a real mystery to me of multifocal contact lenses in general is, why does one patient get such decent simultaneous vision from the lenses and the next doesn't? And it's our belief at Pacific University that maybe it's blur, that some patients can interpret more blur than others can. It may also be some of these anatomical considerations, that the more nasally of the optics the patient is looking, the more decentered the pupil is nasally, the more decentered temporally our contact lenses are. That's going to be create a significantly worse aberrations than if the patient's visual axis lined up on the geometric axis. So I guess one of the things that we want to see with every multifocal contact lens wearer, be it soft or GP, is a patient that has no angle lambda, the geometric axis and the visual axis line up on top of each other, and we don't have any corneal displacement whatsoever. That would be optimal. But since we don't have that, then I think trial lenses are really beneficial if you have them. If you don't have trial lenses, then the warranties are such that you can empirically order, and if it doesn't work out, you can return them for full credit. Next question, could you combine the two designs with smaller pupils, series 2 with the dominant eye and translating with the non-dominant eye if they have a small pupil? And definitely you could use one type of design in one eye and another in the other eye, and certainly that's something that we do regularly with all of the designs. For instance, with the essentials, we have always used a series 1 in the dominant eye and a series 2 or series 3 in the non-dominant eye, just to make sure that the plus was closest to the center. Because the translating lenses have such awesome large add areas, then it may be effective for patients to have a multifocal lens in the dominant eye where they're getting mostly their distance, some intermediate power, maybe not full near power, but some, and then in the non-dominant eye they're getting that full add when they need it. You know, we talk about aspheric multifocals dominating the market. They are because they're relatively easy to fit, they're fairly comfortable, they're relatively easy for the lab to reproduce, so from your end, the practitioner end, you're not seeing a lot of problems with duplicating the lens. The translating lenses really are, the true translating lenses really are awesome at providing good quality distance and good quality near, much better than the aspherics are. The challenge is that we have to have the fit and design just right, and they tend to be a little tougher to work with. Can we use this 11 millimeter diameter centrated design for a plus 15 lens? So in other words, I'm assuming the question would be, could we use a simultaneous vision lens on a scleral? And the answer is yes, but I would be concerned that, like soft lenses, a scleral lens that would follow the natural displacement of the sclera, with the nasal side often being higher than the temporal side, and our scleral lenses riding slightly temporal, then with our nasally displaced optics and nasally displaced pupil, our patient might be looking through the more nasal aspect of the lenses. So definitely something that I personally would like more scleral experience with, but not one I have at this point. Sorry, I may have misread the question, not scleral, but 11 millimeters. So can we use this 11 millimeter diameter centrated for a plus 15 lens? Okay. I'm sorry, I misunderstood. So you're talking about a high power plus lens with a large 11 millimeter diameter. Thank you. Okay, definitely we can use the larger diameter with the high plus lenses. Of course, the question would be, the larger we go and the higher plus we go, the more mass we have. So certainly the lens is going to want to ride, possibly ride lower. That might be a concern, but having a larger diameter, using more sagittal depth, that might allow for a more centered lens. I think we just won't know until we give it a try and actually place the lens on eye. But I certainly wouldn't be afraid of trying a high plus patient in a multifocal lens with the large diameter. I'd probably prefer that way because, again, we're using the large diameter to hopefully center on eye. With the smaller diameters, a real high plus lens is probably going to want to fall off the cornea. Next question. The question was, could we have a bitoric or backtoric translating design, so the back surface of the lens were a bi or back toric, and then using the true translating, the segmented bifocal or trifocal on the front. And the answer is definitely yes. I know a number of the US manufacturers are making such lenses. I'm not certain if they're available in Canada from any of the labs. I can tell you that at Precision we deal only with the aspheric multifocals, but they can be made as back or bitorics. So I think that covers all the questions, everybody. I really want to thank you for your time tonight. It's much appreciated that you all logged in and gave up time for us. If you're interested in any of the upcoming webinars, please let us know. We will send you a follow-up email with the links to both the next webinar in February as well as the Ortho-K and Myopia Control workshops that are coming up in March. So thank you again. Happy New Year and have a great evening.